All right, good morning, everyone. Good morning. I welcome you to day 2 of basic and clinical immunology for the busy clinician. We have an excellent morning lined up for you. Start with a session on COVID, at least what we think is interesting in COVID these days, and end with a session on wellness and the science of wellness. And welcome you all here in person, all our participants online. Thank you to all our exhibitors and our supporters. We have the QR code for the full agenda. And I guess I will get us started here with a talk on COVID for the immunocompromised person. What are we doing? What do we know? COVID is for many better. Omicron is less severe in most cases, and things are getting better. Many think the pandemic is over, which it is not, but things are better. However, for our patients with immune-mediated inflammatory diseases and other immunocompromised patients, this is still here and will be here for a long while. So how do we approach prevention and management of high-risk patients in the setting of COVID? So where have we come? Where are we going? What is the future of the pandemic? Like I just said, it is better for some, but unlikely to fade away, especially for immunocompromised persons. And we envision it morphing into 2 epidemics: an epidemic of healthy, vaccinated persons who will continue to have mild infection and do quite well, and an epidemic of immunocompromised persons who, despite vaccine, are still at risk for more severe outcomes. And these are our immunocompromised persons, and perhaps an epidemic of unvaccinated persons, which is a different story. But this is how we envision the optimal management and education of high-risk patients in the setting of COVID. We envision an educated patient. Patient has to know their risk and to be aware and when to test and what the symptoms are, and to have tests at home. And then they need to know who to call. And then that person that they call, in terms of their healthcare, practitioner, needs to know what to do and what tools we have in our toolbox, both for prevention and treatment, and then how to link that person to the right care path. Just to start, one slide on the new vaccines, the fall booster, the bivalent vaccine. This was authorized back in September. It was talked about a lot, but also unclear kind of what it was and who should get it and what's going on. So just a little update on where we are with that. These are the mRNA vaccines, Pfizer and Moderna, that were reformulated to protect against Omicron. Now this is BA4, BA5. These are earlier Omicron subvariants that we have moved far past, but the vaccines contain the ancestral strain and then these new strains, with the thought we would get an updated, coverage to the current circulating variants. These are now the only boosters available. So if you send a patient for a booster, this is the vaccine they're going to get. And these are recommended for any number of booster the patient is due for. And they're recommended for everyone as a universal recommendation. This is simplified now. Of interest, the ACIP, Advisory Committee on Immunization Practices, met last week and actually added COVID vaccine to the ACIP guidelines for 2023. Interestingly, they also added a sentence on monoclonal antibody prevention and treatment for COVID, which is big. You can mix and match. If they got Pfizer initial series, you can get Moderna. And these offer, at best, modest and transient protection as a booster. And while they're recommended for everyone, we think it's unlikely that everyone needs these, and to focus on more high-risk, immunocompromised, older adults, multiple comorbidities may get some modest benefit from this. I put this just snaps out of a perspective by Paul Offit, who's kind of in line with some of our thinking. Not everyone maybe needs this vaccine. Chasing variants has not seemed to have panned out. As I said, these variants are already many variants ago, and we should stop trying to prevent any COVID and just focus on higher risk patients to prevent severe COVID. And these vaccines do help do that to some degree. So who is at risk for severe COVID? This is a really nice visual from the CDC and IDSA that kind of outlines the heterogeneity of risk factors, and even within immunosuppression, which we know is a very heterogeneous group of persons. As was mentioned yesterday, age is the #1 risk factor for severe COVID, for being hospitalized or dying from COVID. From an immunosuppression standpoint, this is a big spectrum, and we've learned a lot about this since the start of the pandemic. Not all immunocompromised persons are the same. There's organ transplant patients, cancer patients on active immunotherapy with higher risk of COVID. Our patients on TNF inhibitors are not at significantly higher risk. Our patients on B-cell depleting therapy are probably at the highest risk of all the patients we see. And it's a continuum, and it's important to have somewhat of an understanding about which of our patients are at higher risk. And then there's all these other factors that go into it. If they have lung disease, if they're older, all factor into that risk. I show this slide simply to highlight that immunocompromised patients are overrepresented in all studies looking at outcomes in terms of who gets hospitalized on a ventilator and dying. These are mostly in the Delta era, a study from Israel, a study from the US, that immunocompromised persons, in particular patients on B-cell depleting therapy, are heavily overrepresented, and people who are doing poorly in the hospital with COVID. So, what if our patients are vaccinated? No matter how many times they're vaccinated, what are these vaccines doing for our patients? This is a great study from earlier in the pandemic by Al Kim and colleagues at WashU that looked at vaccine effectiveness, the mRNA vaccines, in 130 patients with systemic rheumatic diseases, and show what has been redemonstrated many times that patients on B-cell depleting therapy had a 36-fold reduction in humoral response to mRNA vaccine. Steroids also very significant. Antimetabolites, other heavier duty immunosuppression of hydroxychloroquine does not have significant effect. TNF inhibitors, so B-cell depleting therapy, steroids, these remain huge risk factors for severe COVID, and in part because of their reduced vaccine responses. This is a study from JCI by a Canadian group looking at patients with immune-mediated inflammatory diseases who got 2 mRNA vaccines, and looked at vaccine effectiveness, and highlights that they have waning immune responses after mRNA vaccine compared to patients who are not immunocompromised, with their conclusion being we should continue to boost our patients with additional recommended vaccines due to this quicker waning of immune response after mRNA vaccines. This is a study that we did at the Cleveland Clinic highlighting how B-cell depleting therapy is associated with poor outcomes in COVID, and these were patients who were receiving B-cell depleting therapy across neurology for multiple sclerosis, rheumatology, hematology, and we had looked at breakthrough. So they were appropriately vaccinated and then got COVID, and out of 74 patients developed breakthrough COVID out of 1,600 patients, so 4-5%. And this was up until December of 2021, so pre-Omicron. And then we looked at outcomes using this NIH ordinal scale, 1 to 8. 1 is at home, no problems. 8 is death. And 40% of these patients were hospitalized. 15% of them were in ICU. 8% of them died. And this is quite significant. And we, a little under a third, received monoclonal antibody treatment, anti-spike monoclonal for treatment, early outpatient therapy. And of those patients, they did very well. 1 patient was hospitalized and none died. We looked at a comparator group of patients on B-cell depleting therapy for those indications who were not vaccinated. And interestingly, and perhaps not surprisingly, the incidence of COVID was very similar, slightly worse outcomes. So in summary, before we move on, how are our patients affected differently in COVID? There's increased severity, worse outcomes, including with breakthrough, despite being fully vaccinated, and then vaccines have decreased effectiveness, lower rates of seroconversion, their levels of seroconversion are lower, and their immune responses wane more quickly than persons who are not immunocompromised. So having said all that, what is in our toolbox to prevent and treat immunocompromised patients and prevent them from going into the hospital and dying? Monoclonal antibodies against spike protein. At one point, we had these products available for all of these indications crossed out in yellow. And unfortunately, right now, we have no monoclonal available for any indication. But this will change. The reason for this is these all target the spike protein, which is highly susceptible to mutations, which we'll talk about with the current circulating variants. So these are all, many products have come and gone since the start of the pandemic and have lost effectiveness and were taken off the market. But many are in studies right now and will have more soon. But it's a moving target. This is from a study I just showed, our study focusing on the patients of our breakthrough cohort of B-cell depleted patients who did get monoclonals, with the total cohort being up here. This is the NIH ordinal scale. The darker the blue, the better the outcomes. So these are the patients who received early treatment with outpatient monoclonal antibody of the time, and they all fared very well. One patient was hospitalized. This patient got their monoclonal antibody on day 10, which is the end of the window, and was hospitalized that day and still did just fine and was discharged. So this was and will be an important tool in our toolbox for preventing progression to severe disease in immunocompromised patients, especially B-cell depleted patients. This was perhaps the highest point of treatment options during the pandemic. Pre-exposure prophylaxis with long-acting anti-spike monoclonal antibodies, tixagevimab, silgavimab, called Evusheld. This was such an excellent tool in our toolbox for prevention of COVID in our patients. Like the other monoclonals, this was taken off the market not too long ago due to loss of effectiveness against circulating variants. But a new product will be with us soon, we hope. This received authorization for PrEP, or pre-exposure prophylaxis, in December of 2021. It is a long-acting anti-spike monoclonal antibody given as IM injection and then lasts for 6 months and was redosed after 6 months. It was indicated for patients who were deemed to be at high risk of severe COVID despite vaccine. So they had not responded to their vaccine appropriately, or if they had a significant contraindication, allergy, et cetera, to being vaccinated. Not a substitute for vaccine, but an adjunct, an extra layer of protection for our patients. This was our early experience with tixagevimab, silgavimab, patients on B-cell depleting therapy, and patients with inborn errors of humoral immune deficiency from January through the end of May 2022. All of these patients that we gave tixagevimab, silgavimab to, we looked at who got breakthrough COVID. 12 patients out of a little over 400, or less than 3%, which we thought was great. Those patients who had breakthrough did very well, with one note being patients who did develop breakthrough were treated appropriately still with antivirals or monoclonals, which is standard of care for high-risk patients who get breakthrough. But this was very reassuring to us, our early experience. How did we look at prioritizing PrEP? This is how we approached at the Cleveland Clinic. Early on in tixagevimab, silgavimab availability, the allocation was very small, and we, triaged our highest risk patients, B-cell depleted patients, cyclophosphamide, anifrolumab, a type 1 interferon receptor blocker. Could imagine how those patients are at higher risk of severe COVID. Later on in the PrEP story, middle to end of last year, where there was a lot of tixagevimab, silgavimab, more than anyone was using, and there's a lot of reasons for that. Lack of awareness, unclear who should get it, was heavily underutilized across the country. But this was our approach. The indication in the EUA is really for any immunocompromised persons, but kind of going back to that slide I showed earlier, we have learned which of our immunocompromised patients need things like PrEP, and they're probably not patients on TNF inhibitors or many of our new psoriatic disease biologics. There's not found to be an association with severe COVID, patients on methotrexate monotherapy, healthy people on azathioprine, et cetera. But this was our approach. There is a tixagevimab, silgavimab 2.0 trial ongoing right now called Supernova, and hopefully we'll have something available later this year. Right now we're in a monoclonal antibody desert. These variants that are currently circulating are to blame for our lack of monoclonals right now. The XBB is the majority of cases across the United States right now, and BQ1, these are Omicron subvariants that are heavily mutated. And this table just shows in orange is bad, yellow is bad. This was one of the more recent monoclonals for treatment, bebtelovimab we were using, and this is PrEP, and they're lost effectiveness completely. The convalescent plasma story is one that is of increasing interest to us for a couple of reasons. So convalescent plasma to treat patients with COVID and prevent severe disease. This has been of interest since the start of the pandemic. This is pooled plasma from patients convalescing from COVID. And there have been many studies since the start of the pandemic with variable results. Many randomized control trials that were halted for lack of effectiveness, but there does appear to be effectiveness in preventing severe disease when given an early outpatient setting, and also in immunocompromised patients perhaps later in their course, and high titer convalescent plasma is best. And we at the Cleveland Clinic are using this right now in patients on B-cell depleting therapy who have this protracted, prolonged COVID and are still testing positive. If you do a BAL, they're still testing positive down in their lungs, and we're giving them convalescent plasma. It can be a challenge to get from time to time, but this is of increasing interest because it is, reflective of the current circulating variants and is effective in real time, unlike monoclonal antibodies, and is polyclonal. And the variants I showed on the previous slide, I said they were heavily mutated. They should actually be considered to have shifted instead of drifted. If you think back to how we learn about influenza mutations, shifted viruses is bad and much more heavily mutated than antigenic drift. And so these polyclonal response in convalescent patients are very effective against treating COVID. And so this has kind of been reinvigorated our interest in convalescent plasma, and we'll see where it goes. But use in early disease and use in high-risk humoral immune deficient patients later in disease. And it's interesting because now we have increasing data that patients with hybrid immunity have, excellent neutralizing antibodies. So convalescent plasma from persons who were vaccinated and or infected is likely to be a highly effective treatment option right now. Moving on to antivirals, a tool we currently do have in our toolbox and is of excellent at preventing severe COVID in our patients, and a couple options, a couple things to know about how we're using these products available to us. Nirmatrelvir, ritonavir, or Paxlovid has been available for a little over a year. This is an oral antiviral, a 5-day course that's given within 5 days of symptom onset. And in this pivotal trial, the EPIC-HR was shown to reduce progression to severe disease in over 80% of persons. And these are high-risk patients, patients with risk factors for progression to severe disease, whether it just be age alone, immunocompromised, diabetes, lung disease, etc. Given within 5 days of symptoms, almost 90% effective. There are a lot of drug interactions. This is a great option, but is limited use in a lot of patients on a lot of drugs. And IDSA has a great drug interaction checker. There's many different calculators out there. The big culprits are anticoagulation, antiarrhythmics, anti-rejection medications. Unfortunately, a lot of medicines that patients can't stop and limits the use of this, but definitely consult with your friendly clinical pharmacist when prescribing this and make sure you know what drugs your patients are on. Statins are another one. Just 2 weeks ago, the indication or distribution, prescribing of Paxlovid, they updated that you don't need a positive test anymore. You just need a clinician diagnosis of COVID, which is nice. And in some states, pharmacists can prescribe Paxlovid. The EPIC-HR study, from the data I showed you on the previous slide, was done, all these studies were done pre-Omicron, pre-vaccine even. So how is this working in the real world now in the Omicron era? This was published a couple weeks ago from a Colorado health system looking at effectiveness of nirmatrelvir, ritonavir in the Omicron era outpatients who got this antiviral. Almost 10,000 compared to 20,000 who didn't, and still showed significant decrease in 28-day all-cause mortality in patients who did get antiviral versus not. And all these studies are difficult now. Was mentioned yesterday, the primary outcome, hospitalization or death, is low across the board, but still, despite that, patients who do get antivirals do have decreased severe COVID. Well, molnupiravir is our other option, perhaps slightly less exciting option, but it's good to have options. It's another oral antiviral authorized around the same time as nirmatrelvir. Same indication, given within 5 days of symptom onset. The Move Out trial demonstrated, unfortunately, only 30% effectiveness in high-risk patients. And I'll say that all of these studies, our patients, immunocompromised patients, are heavily underrepresented in these studies. And we think that these drugs probably have even more benefit in our patients. But 30% effectiveness, there are no drug interactions. You cannot give it to children or pregnant persons, no adjustments for hepatic or renal disease. So it is an option for your patients who are on one of those drugs that you can't stop, like rivaroxaban, et cetera. This study, Panoramic, was done in the Omicron era. It's a UK study looking at outpatients with risk factors for severe disease who got molnupiravir plus standard of care versus standard of care alone. And the primary outcome, hospitalization or death, was seen in only less than 1% of the entire cohort. So there was no impact on mortality. And compared to down here, this is a pre-Omicron study by Sun and colleagues, just to compare hospitalization rate of immunocompromised persons. Pre-Omicron was significantly higher than less than 1%, but morbidity was significantly decreased in patients receiving molnupiravir. They improved on average 4 days quicker and had a significant improved rate of viral clearance by 1 week, shown here in this nice tweet by Paul Sachs, infectious disease doc at the Brigham. If you're on Twitter and don't follow him, you should. He gives excellent up-to-date information in real time on COVID. So no significant impact on mortality in that study, but morbidity was reduced. This is just one more slide to drive home the point that while things are better, Omicron outcomes are improved. being vaccinated is still important, and our antivirals are still working. This is a US registry looking at patients by Omicron and Delta era and by vaccinated or unvaccinated, looking at severe outcomes, hospitalization. We're better in vaccinated persons. We're significantly lower in the Omicron era compared to Delta. Patients, while it was improved outcomes across the board, they were even better if you were vaccinated. So in summary, less than 1% of high-risk patients infected with Omicron seem to be hospitalized in that panoramic study. And for those who are hospitalized, risk of poor outcomes is significantly less with Omicron compared to Delta and prior variants, and even more if you're vaccinated. Of course, our talks are never up to date. Just 2 days ago, a study was published in Clinical Infectious Disease looking at immunocompromised persons in the Omicron era, mainly transplant patients, solid organ, allogenic stem cell transplant, some B-cell depleted patients, but they showed, despite Omicron era, 20% of those patients, and despite vaccine, continued to be admitted to the hospital with severe COVID. So the pandemic is still with us, especially for our patients. This is a nice study by Jeff Sparks and Zach Wallace looking at outcomes specifically in our patients in Omicron era compared to earlier eras. It was retrospective, 1,500 patients with immune-mediated inflammatory diseases, and again, demonstrating like in the general population, severe outcomes decreased over time with Omicron and better if vaccinated. So this still applies to our immunocompromised patients. We continue to have challenges with distribution, awareness, acquisition, and administration of all the tools in our toolbox, and there are a lot of reasons for this. Early on, it was lack of availability. That's not really a problem anymore, and everything remains free from the US government, although this will be changing sometime in the not too distant future. And also lack of awareness on the both provider and patient side, from logistics to who needs it and so on. And this has been a great challenge. And we need education on this for across the board. This I put up here, this was posted on CDC 2 weeks ago. If you have a weakened immune system, look at this, and it says get vaccinated, it says open the windows and wash your hands and test yourself, but doesn't really tell you to call your doc about oral antivirals or anything else. So we need more education for patients and providers. And this is complicated. Our patients see a lot of different doctors. We have shortened time with our patients in the clinic, who's going to tell them about their risk and what to do and who to call. It's not always clear, but if we're immunocompromising patients, this should be our job, and someone has to talk to patients about this optimal cycle of education and awareness and what's available and who to call, because they might go to the emergency room and not be offered any of these treatments, or by ER providers who don't often interact with our patients. We published this in Arthritis and Rheumatology with Kevin Winthrop, how we think this should be approached, and call for all practitioners who interact with immunocompromised persons to have awareness of prevention, treatment options, and education both for themselves and for their patients, so we can continue to optimally manage our patients moving forward in the pandemic, which, while it's getting better for everyone else, will be here probably forever for our patients. So understanding who's at highest risk and how to counsel them and what's available to prevent and manage and keep them out of the hospital is going to be really important moving forward. That was all I had. I thank you. We'll do questions at the end of this session, but thank you. Thank you very much. Next, we'll move on to a talk about long COVID, a hot topic by someone who knows a lot about long COVID. Dr. Calabrese, take it away.
I didn't get much of an introduction from her. I don't get it. So, that was a great introduction. We wrote that piece almost a year ago about how we envision interacting with our immunocompromised patients, and it's as timely right now as it was when we put it out, and it's actually more important because we have so many more tools and changing landscape. So we're going to come back to that time and time and time again, and it's education, patients, education of clinicians, and having the tools available. So long COVID. This is an incredibly controversial, complex, evolving part of the pandemic. As Cassie said, the next phase of the pandemic not only will be facing challenges of immunocompromised patients having acute issues with SARS-CoV-2 infection, but the next phase of the pandemic will be heavily oriented around this changing landscape of long COVID. Unfortunately, this is not a topic that can be done in a short time, so I'm going to do my best. And it's very interesting when you hear a talk on COVID by people that do this for a living. As Cassie must have had 5 references that were in the last 2 weeks. I've changed this talk 5 times in the past 2 weeks as well. So what is it? What's the epi? What's it clinically look like? What do we know about pathogenesis? What are the controversies, and what are we doing about it? So I tried to figure a way of projecting this, and I redid this last week. So this is not the 3 phases of that diagram that we showed about COVID-19. This is about, you get COVID-19, you either recover from this, from a mild infection or moderate infection or a severe infection, and you get better, or you don't get better. And this, at the end, is showing you the common sequelae. Those are conditions that are the consequence of previous disease or injury. And the more common things are neurocognition, fatigue, breathlessness, pain, etc. And you can get there from having terrible COVID. You've been in the unit, and everyone would understand that. You come out of the unit, you're sick, and we've known that for time and memoriam. On the other hand, the first number over here, these are people that are healthy and have posse-immune or posse-symptomatic COVID-19. You have a bit, you had a respiratory illness, and then they fail to totally recover. That has been the challenge, and somewhat inexplicable and fearful to all of us. I recovered from that, but I'm not the same person. So how do we look at this? What is this has been referred to as long COVID. It's been referred to as PASC, the sequelae of COVID-19. The people who have disorders under that umbrella have often been referred to as long haulers, so I'm using some of these terms. We as rheumatologists, we're so attuned to having classification and striving for diagnostic criteria. We don't really have universally accepted classification criteria for long COVID, but there are a couple of definitions that are commonly used, and the one that most of us use who are studying this of the WHO. And it says a condition that occurs in people with a history of, it said, quote, confirmed COVID-2 infection, and that's changing. Usually 3 months from the onset of symptoms, lasts at least 2 months, so it's long, and cannot be explained by other or alternative diagnosis. Not every person that has a terrible headache, worst headache of their life a month after COVID has long COVID. They need to be worked up for the worst headache of their life. So there's an implicit diagnostic urgency for these. But if you take this definition, 3 months, failing to recover, most of these people are complaining of fatigability, shortness of breath, cognitive dysfunction, and pain. This I consider one of the most important publications of last year in COVID-19. I urge you all to read this. This is by the Yale group led by Akiko Iwasaki. And it merely re-examined what many of us have known for decades. And this is kind of the irony of long COVID, that unexplained post-infectious syndromes are not new. We have been seeing patients with these for years, but the irony is that they have been marginalized. People had said, oh, I had an infection. I don't care if it was Lyme, I don't care if it was EBV, I don't care if it was some unexplained respiratory illness, and my life has changed. While the data on what may be driving this, whether you need an antibiotic, don't need an antibiotic, that's all very controversial. But patients who are sick after infectious diseases, they're sick. And their voice is the most important part of this. And this has been well documented by numerous detailed studies, and we need to respect that. Moving into long COVID at a glance, this is a famous figure from one of the early clinical papers that looked at a kind of a heat map of the frequency of different complaints. And you can see that it is often dominated by fatigability, but there are many other symptoms that are quite common, and they're hugely diverse. And yes, these are often measured by quality of life determinants, because people are telling you that my GI tract is bothering them, I have fatigability, I have neurocognition, I have pain or shortness of breath. These are the most common within this, and these are so difficult. We as rheumatologists know these symptoms very well. We see these all in our patients with immune-mediated diseases and without immune diseases. So this is the landscape of this, and how can we make sense of this given the ubiquity of this clinical spectrum? For the rest of this talk, I'm going to classify this post-COVID sequelae into two groups. The one is those that have persistent symptoms secondary to some defined pathology. You're in the unit, you come out, you're on a ventilator, you have pulmonary scarring, and you're breathless, or you had microvascular occlusive disease, you have PTSD from being in the hospital. We set those aside. We have understood that form of illness for many years. And that is serious and it's bad, but we have come to grips with it, and it's a relatively small part because they have a defined pathology with or without symptoms, and we'll set that over here. Where I'm going to focus the rest of this talk are those with persistent symptoms without defined, or should we say interpretable pathology. When I say without defined pathology, that doesn't mean there's nothing wrong. That means that we have yet to understand the pathologic basis of this, but we're getting there, as I will show you. This is where we're talking long COVID and long haulers. So with those limitations, what do we know about the epidemiology of this? I have tried to project this in numerous ways. And if you look at the literature and you Google, how common is long COVID, you will find data saying from 1 to 50% of people have had COVID. It's insane. And how do we make sense of it? So I will show you in a minute my view of this, at least using the best available data. The challenge is, as I pointed out, is that if you don't have classification criteria, what are you measuring? I just don't feel good, or, I meet some type of criteria. So there's, secondly, many of the studies have used variable levels of evidence that they actually had infection. That may or may not be important, and I'll come to that at the end. It's one of the controversies. Like at first they said, well, you haven't proven this because you didn't have a positive test. Our tests are imperfect, and what we're seeing is that there are post-acute sequelae from respiratory infections that we've not appreciated prior to this. We would love a biomarker. We'd love to have an ANCA test to do this that has high sensitivity and specificity. And while there are a myriad of biomarkers that have been reported, hundreds and hundreds, and often using deep immune profiling, proteomics and microbiomics and beyond. None of them have the crisp test operating characteristics of known sensitivity and specificity that we can use to do this now. I don't care what anyone says about that. And then the study designs that have gone into this epidemiology. Some of them have been launched on social media. And so people can go on social media and say, I had COVID and now I have long COVID. So you're going to get a certain picture of that. Others have used health services techniques, looking at electronic medical records. Well, that's only what people have recorded. And there is no, while there is a long COVID ICD, there's no definition of what to put into it. So that is a limiting factor. And then there are active study designs that are now curating patient populations who had respiratory illnesses with or without documentation of COVID, and then really following them and asking them. That's where the money's at, and that's where I have my own beliefs. So this is from something called the Household Pulse Survey. So, segue here. Who's following the Bing artificial intelligence new search engine? One person, I'll talk to you later. All right, so forget it. I'll move on from there. So I actually tried to use that to make this slide. It didn't work very well, but the Census Bureau is doing a great job, and they are sampling households and on a regular basis, tens of millions of people, and they are asking questions of adults greater than 18, have you had COVID-19? Did you have a positive test? Yes, no. If you had a positive test, have you experienced symptoms that you didn't have prior to this for greater than 3 months? If you had that, and we know the dates of all this, are you still experiencing it? And then, how much has this affected your life? And they have some gradations, a little bit or a lot. So doing that, you can come up with some interesting data. We now estimate conservatively that 125 million people in this country have been infected with SARS-CoV-2. It's probably much more than that if you consider children that probably all have been infected and we don't know about it. It's a bit hyperbolic, but you get what I'm saying. If we use these numbers, you can see that an estimated 28% of those people who had COVID had some form of long COVID experience, and about 6% of them are currently experiencing long COVID. That's 7 million people. Why am I getting this echo here? And of those people, about 1.9 million have significant limitations. This is serious stuff. This is a lot of people in the country at the present time. And if you look at the most common symptoms they're complaining of down in the lower left, it's fatigability, shortness of breath, neurocognition, pain, and a number of others. Loss of taste and smell is going down because that is disappearing from current variants and subvariants. So if that's the architecture of the epi, what are the risk factors and endotypes? Well, we know that being older, children can develop this, was very unusual. Being over the age of 40 puts you in a higher risk category. Females to males, 2 to 1. That is not a pejorative statement. That is an epidemiologic statement. And we are used to this in rheumatology. Just because more women get lupus than men doesn't mean that it is some type of gender disequality based on strength of will. It is clear that if you have more severe COVID, you're at a higher risk than mild COVID, but you are not totally protected from symptomatic. We're learning a lot about social determinants of health right now, and minority groups, underprivileged, poverty, et cetera, are risk factors, and this needs to be further analyzed. And then your previous state of health as well. You're protected if you're young, you're vaccinated. There is some evidence that if you get a prompt antiviral therapy, you may be protected. And it is less common in the Omicron era than before. So it's unknown at the present from rheumatology perspective. The question we should have is that do patients with RA and lupus and Sjogren's and all that, are they at greater risk? Are they at less risk? And if they get it, does it look the same or does it look different than people without immune diseases? Don't know. Do not know. And there are people, I mean, we're trying to get our hands on this. The Brigham Mass General just awarded a NIH grant to help sort this out a bit. I look forward to this, but this is the future for us. So if we use that as the basis, what does this disease look like? Well, you know, if there are 50 symptoms, and if you read the lay literature, some people claim that there are over 200 symptoms associated with long COVID. I don't know what that means. I can't imagine 200 symptoms of anything, but it's a lot of symptoms. And out of this soup, there are certain patients that stick out. And so there have been attempts to categorize these on the basis of clinical endotypes, and these are the most common, and I'm going to make a few comments about each of these. So this was an interesting study from last year that used AI approach by taking large numbers of patients and then trying to segregate them into endotypes that held together using like single component analysis, very, very sophisticated statistics. And I will tell you that most of them, so we have a cognitive pattern, a pain pattern, a pulmonary pattern, cardiac, anosmia, dysgeusia. The only one that looks really weirdly different is the anomia dysgeusia. The rest of them are well represented with myalgia, arthralgia, sleep disturbances, fatigue, and pain. Those are the things that are at the heart of this. Now, some people have far more fatigue than pain. Some people have far more pain than fatigue. Some people are totally debilitated by neurocognition. But these are endotypes that we don't know are caused by different factors. They have different pathogenesis, but these are things that we are seeing in our clinics. The most common symptom of patients who have chronic fatigability, chronic or long COVID, is fatigability. And this has been looked at very carefully now by numerous groups. And I'm showing you some data. This bar graph on the right is a study from Harvard early on, looking at varying symptoms in a cohort of patients in their long COVID clinic. And in the lower left-hand corner, these are the Institute of Medicine criteria that are now 8 years old that defined what those of us that have worked in the field of myalgia, encephalomyelitis, chronic fatigue syndrome, MECFS. And that disorder, which is maligned and marginalized, recognized there were people that had persistent fatigue for 6 months, unrefreshing sleep, with this feature of post-exertional malaise, where activities and daily activities that usually you well tolerated, whether it be work, play, stress, intellectual stress, orthostatic stress, could wind up with great exacerbations of these underlying symptoms. And then most of these patients had either brain fog or dysautonomia, and 40% of them would meet criteria for fibromyalgia. So these are patients that we know. We understand this. So on the right, it showed that in this Harvard cohort, most of them would meet the Institute of Medicine criteria for MECFS. And in the lower left, I make a note that Hector Bonilla, who runs the long COVID clinic at Stanford said of their first 96 patients, 52% of them met criteria for ME/CFS. So this is a common endotype that we see, and it is probably the most heartbreaking and difficult, both for the patient and the clinician, but that's the reality of life, and we can't make it go away. Another clinical endotype is that of autonomic dysfunction. We should be very interested in this. You know, there are no other subspecialty of medicine with so many clinical trials of autonomic manipulation, you know, going from implantable vagal nerve implants to those that are external, et cetera. We understand that the autonomic nervous system controls pain and inflammation and beyond. Within the long COVID spectrum, patients can have what has been referred to as COVID tachycardia syndrome. People who have had COVID often can recall waking up in the middle of the night with tachycardia. This has a tendency to subside over a few months, but in its fully developed form, they will actually develop postural orthostatic static tachycardia syndrome that can be highly debilitating. This often occurs in the setting of small fiber neuropathy and can be seen in patients who are vaccinated. I have a number of patients who have developed severe POTS after mRNA vaccine. Epidemiologic data suggests that it is 500% more common to get dysautonomia after COVID than after vaccine. But there are, you know, these inexplicable things that we're recognizing right now, and it's important. The natural progression of that is one to improve over 12 months, though not all people improve. We have a monthly conference on long COVID, and a month or so ago I had Dan Claw, who, known to the rheumatology community, is probably our leading academic figure in pain, international pain expert from U of M. And he made the point that much of the long COVID phenotype or clinical endotype is consistent with fibromyalgia, and that fibromyalgia has been well recognized to occur in the wake of other infections, and this has been looked at for decades after alpha virus infections like Ross River, and after EBV, and after other conditions. And I will just tell you, because you guys will appreciate this, that, you know, I go to all these long COVID meetings, and I, you know, hang out with mostly ID guys and immunologists and people doing research. I have never heard the word fibromyalgia even uttered in any meeting that has had anything to do with long COVID. It's not even in the lexicon. And it shows where the disconnect is right now between all the blind men on the elephant. But I think it's starting to close right now, and we are now launching into a study to look at that, because we are now starting to understand fibromyalgia as a far more physiologic, neuropsychoimmunologic illness than we have ever appreciated before, and I'm very excited about it. The neurocognitive aspects of this are of great distress to many people. The Pulse survey showed 1 in 4 complain of difficulty concentrating. Detailed neurocognitive analysis, Igor Koralnik from Northwestern spoke at our meeting recently. Most of these people have deficits that some are mild. They are not dementia. This is not a progressive form of dementia. It mostly affects attention, processing speed, and executive function. When patients have told us, I have brain fog, that's what they're telling us in long COVID, and it is very distressing when it's present, and it needs to be validated, and this has a tendency to improve, but we'll come back to this at the end. The risk factors for cognitive sequelae are here, and it is not social determinants of health, older age, Also pre-existing or intercurrent disorders of mood, depression, anxiety, PTSD. That does not diminish this, but tells us that there are neural pathways that are active. All right, in the last few minutes, I want to, am I doing my time here? Oh, good. All right, moving along. So what may be causing this? Well, the first answer is that we don't know. And as I said, of all this clinical endotype, whether it be one or many, we don't know whether these are connected or unconnected. There are a number of putative mechanisms with varying levels of evidence that need to be sorted out. And this is a very nice figure by Mike Peluso and Steve Deeks from UCSF, published last year, which I think is still quite accurate. And I'm going to go through some of these, but there are theories now that will be tested that this is due to some form of persistence of viral infection. And you heard Dr. Silverman yesterday talk about this persistence in the GI tract, very well recognized. Secondly, there is interest that these may be related to inflammatory pathways. So there is a disconnect of inflammation, clinical inflammation in patients who have this. There's a very important study done by Mike Sneller at the NIH that looked at detailed laboratory testing in 100+ patients with meeting this kind of loose criteria for long COVID, and using clinical tests that we have, in autoantibodies, CRP, like immunoglobulins, blah, blah, largely unimpressive. However, looking at inflammation with deeper immunologic profiling, as I said yesterday at my lunch talk, there's a statistical increase in IL-6 levels, usually a few picograms, and other IL-8, et cetera. The immune system has not been reset, and if you look at the interferon signature, there is a persistent interferon signature even at 8 months, and that's well controlled compared to other respiratory infections and other coronavirus infections. So is that playing a role? And I mean, because these are all treatable targets, right? Reactivation of other viruses. It has been quite clearly demonstrated that risk factors for developing long COVID are that if you have acute COVID and you become EBV viremic, we all reactivate EBV periodically, that is a huge risk factor that you will develop long COVID down the way. So is EBV reactivation doing that? CMV, on the other hand, seems to be protective, at least in some studies. I won't talk about the microbiome, but there's evidence that even 18+ months after COVID-19, that there are persistent changes in microbiomic patterns, both for diversity and enrichment, and whether that now, dovetails back to what Dr. Silverman is talking about, how it affects our integrated immune response. Is that just a passenger or a driver? We don't know. I'll talk to you about probably the hottest theory at the moment, which is the clotting issue. And then I'll talk about autoimmunity. I talked a little bit in my introductory talk. And then there are certainly other things that we don't know about. So this is the hottest theory of going on in this world. I'm just interested. I'm going to do a poll here. Who's heard of this concept that microclots are in patients with COVID-19? All right, okay, this is big. Well, it made the cover of National Geographic, so that's that last month, that was big. And I was telling this to one of the scientists at the Cleveland Clinic. I said, this is on the cover of National Geographic. He said, I wasn't aware that was a peer-reviewed journal. I said, oh, just shut up and listen. That was Keith McRae. So this is interesting stuff and quite controversial. So a group from South Africa, Risha Pretorius, working with a guy in Liverpool, Douglas Kell, have been studying this phenomena for a number of years. And so we understand blood clotting. I mean, we're rheumatologists, I understand that, fibrinogen turns to fibrin and mixes with platelets, and that's what a blood clot is, and we can lyse it, and we can prevent it with anticoagulants, and, that's kind of our medical school background. That is blood clotting. As it turns out, in this condition, as well as in many other conditions, and I will tell you that in this, type 2 diabetes and rheumatoid arthritis, and I was unaware of this literature, there is another form of clotting, that fibrin, under the influence of inflammatory stimuli like lipopolysaccharide or spike protein, converts to an alternative form of clot that they call fibrin amyloid microclot. And so it is fibrin, but its primary amino acid structure has been modified in a way to make it amyloid-like, so the beta-pleated sheet. This is not amyloid, this isn't amyloid protein. This is fibrin that has now taken on an amyloid composition. And in the presence of this stuff, which can be seen under the microscope, here's a normal person. These are people with varying forms of long COVID. These are aggregates. This is staining with an amyloid stain, and this is platelets mixed in with this. And these can be 15 micra in diameter. I mean, capillaries are only 8 micra. And that's kind of scary. But they are like jelly-like, and they can pass through. Anyway, everyone in the country is now trying to duplicate this. And she's a great scientist and is collaborating and has taught these techniques at Yale and Harvard and UCSF. And now they're learning to quantify them by flow cytometry, et cetera. Are these causing the neurocognition? Are these causing the activation in the central nervous system? Are they playing a role here, or is this an epiphenomena? So more to be seen. They have just reported a clinical trial of using 3 different antiplatelet anticoagulants in 32 people. It wasn't a very good trial, but with very positive results of people feeling much better from all these subjective things. I showed this picture yesterday. I'm not going to show it again. After COVID-19, you make autoantibodies. It's incontrovertible. Are these autoantibodies, and the sicker you are with COVID-19, the more autoantibodies you make. Are they sicker? Do they drive these symptoms, or are they epiphenomena, just immunologic network? We don't know, and this is some people look at this as a target of treating autoimmunity. I'm not going to talk about any of the other theories at the present time, but I'm happy to answer questions later. As I close, there is a debate about this, and it is a very acrimonious debate. And Cassie laughs at me because when I tweet about this stuff, about half the time everybody thinks I'm a genius, and about the other half is like I'm the biggest idiot in the world. Don't you understand anything about long COVID? And I said, actually, I do. And I've never experienced anything like this. So some of the debate says, oh, this is all exaggerated. These are just, depressed people. And that is far from the truth. And maybe we have this all wrong. But I just point this out because patients who will come and discuss this come with this social framework in the background. What do we do about this? Well, there are no approved therapies for long COVID, obviously. And there are clinical trials that are afoot right now. And, I told you that persistent viral infection has been looked at, and the NIH is launching a 1,700-person study of Paxlovid to RCT to look at this. People that have fatigability and dysautonomia can benefit from cardiopulmonary rehabilitation. But it needs to be done by people that really understand how to do this, and this notion of pacing. And I don't have time to talk about pacing, but this is kind of the opposite of graded, get a personal trainer and let them whip you into shape. This is going at your own pace allowing recovery between rehabilitation episodes. Psychologic support is huge, and in the neuropsychoimmunologic model, I think this is more important than we have ever given it. There's a small pipeline of experimental therapies, including antivirals, immunomodulatory, chemokine active, and metabolomics that are going on, and autonomic targeting, just like we are using in our diseases. And then I think hugely, this is a great place for integrative medicine, a segue to our final topic, because many of the techniques that have been around for eons may be addressing some of these ubiquitous symptoms that we are now starting to understand on a molecular basis. All of the major medical centers across the country are developing these long COVID clinics. We have one called the Recover Clinic that was started in 2021 and has well over 2,000 patients in it. It is a wheel and spoke clinic like all of these. If you have your breathlessness, you go to the cardiopulmonary track. If you have neurocognitive, you go to the neuropsychology track. If you have pain, you know, it's either pain or rheumatology or something. It is puny in the instruments, but we're learning a lot from all of these. This was a nice, a very thorough review by Eric Topol way back in January of 23 that are looking at treatments that are now being used or studied for all of these symptoms. You can look at this at a later time with varying levels of supporting evidence. But, you know, people who have POTS, they should be taken care of by people that do take care of POTS. There's lots of tools, a lot of vasoactive drugs. People who have pain, I think that the pain that they have is very reminiscent of nociplastic pain, or what we now we used to call fibromyalgia, and pain people call nociplastic pain. And I think that we're going to hear a lot about mind-body approaches to this. I'm very hugely supportive of this. Post-exertional malaise and pacing, all important. I close with this. I wrote this with Luana Koloka, who is a leading placebo-nocebo scientist very early in the pandemic. And we believe that, you know, hearing patients, that interacting with patients in an empathic and open way has healing effects itself. I'm not talking about lowering viral load. I'm not talking about getting you off of the ventilator. But these symptoms that I'm talking about are tied into networks of neuropsychoimmunologic dysfunction that we're now just starting to get glimpses of, and that can be exacerbated by states that allow us to be under continuous stress and threat. We, you know, every day that we wake up, you know, we're parsing, I don't want to feel too fatigued, I don't want to be too achy, I don't want to be too groggy, and our brains are balancing this, and we have these soothing networks that keep us normal. That's the whole idea of fibromyalgia-ness, like Fred Wolf. We all have these symptoms. It's part of the fabric of life. When it gets like this, it's not because we're puny or weak or we can't handle it. It's that the pathways that modulate these are awry. And I will tell you that COVID-19 has made them far awry. So the starting point of taking care of long COVID is that, yeah, we treat the symptoms and we try to, you know, deal with them the way I've just talked about, but we empathically try to understand their experiences of their sickness. Saying a person has long COVID has tremendous personal dimensions, and this may carry a lot of baggage to a person. Like, you know, you don't know what they understand of this. It is easy for us to validate patients' symptoms without telling them that we understand them, but this can expunge people of guilt. I do this with fibromyalgia, and I'm sure every smart person here does this with people. We have no cure for these things, but we validate them, and we can dispel their fears. There are certain positive things going on here of natural history of improvement. This helps us enrich our relationship, and helps them find meaning and compassion for us as well. Yeah, I don't mind seeing patients with this at all. I actually find it very, very enriching. Takes time, but we usually have some positive aspects. Anyway, I'm going to stop. This is just the snapshot version of this. I've gone over my time, and we are now going to transition to across the pond. Thank you.
Thank you. That was fabulous. To round out our COVID session, I'm delighted to introduce my friend and colleague, Puja Mehta, who we so wish was joining us in person, but will be joining us virtually from her home in London. She's a rheumatologist at University College London, where she's completing her PhD in immunopathogenesis of post-COVID interstitial lung disease. She is an expert in all things systemic rheumatic disease in the lung, including COVID and the lung. She's going to talk to us about cytokine storm in the setting of COVID and immune-based therapies. And I believe she has strep throat and gets bonus points for joining us today. And we won't make her talk too much during our virtual panel. She recorded her talk yesterday and will be joining us live for panel discussion afterwards. So welcome, Puja.
First, thanking you for the invitation. I would have loved to be there in person. It looks like a stunning programme. And I'd also like to apologise because I woke up with strep throat and feeling quite croaky, so I apologise in advance if there's any coughing or croakiness. So we'll start with the rationale and hypothesis for immunomodulation of COVID, a high-level contextual overview of established cytokine storm syndromes, move on to immunomodulatory drug trials, the approved and the others, and then we'll end with future directions and unanswered questions. Making the slides for this talk actually made me realize how far we've come. This hypothesis was first proposed in March 2020, 3 years ago now, which feels like a million years ago. And we and others, including the International MAS Collaborative, suggested that all patients with severe COVID-19 should be screened for hyperinflammation. And we now know that the H score for HLH is not useful to identify this group of patients, and that IVIG or convalescent plasma are not effective. But we do have evidence for steroids, tocilizumab, JAK inhibitors, and even anakinra in certain populations. Making these slides also reminded me of the criticism that came with this proposal. Now, it was great because the proposal was that hyperinflammation was involved in the etiopathogenesis of severe COVID, served as a catalyst for numerous clinical trials of immunomodulatory strategies in this space. But I do remember the barrage of criticism, and I'll share with you today, I even received death threats on Twitter. Now, in scientific circles, this was appropriately challenged. In non-scientific circles and amongst some scientists, there was quite a lot of aggressive pushback. Some questioned the definition and the low IL-6 levels, the risks of immunomodulation, and the concept of potentially distracting focus from antivirals and vaccines. The terminology certainly has been emotive and polarizing, perhaps more on my side of the pond. Prof. David Fajgenbaum from Penn and I reviewed the hyperinflammatory debate. And I think, again, it's interesting to reflect that in America, you're very comfortable with the term cytokine storm, whereas in the UK, there was massive backlash. And now we tend to use the more muted hyperinflammation, something interesting to think about. So I think we really do now know that severe COVID-19 meets the New England Journal definition for COVID-19 proposed by David Fajgenbaum and Carl June. COVID in the severe form is an immune dysregulation state with elevated cytokines, acute systemic inflammatory symptoms, and secondary organ dysfunction disproportionate to the initial trigger. We've all grown to know and love this figure from Scott Canner and colleagues. The umbrella term cytokine storm syndrome or hyperinflammation is a unifying catch-all demonstrated by this beautiful figure with COVID-19 residing as a distinct entity under the umbrella. Now, in brief, the etiopathogenesis of cytokine storms is not fully elucidated, but it's thought to occur in an immunogenetically susceptible individual, where a trigger, such as a viral infection, results in dysregulated immune activation with an exaggerated autocrine loop of pro-inflammatory cytokines, giving rise to these very severe clinical sequelae. And most of these are druggable therapeutic targets with existing therapies with known safety profiles. In our framework for managing conventional cytokine storms, we suggested switching off the cytokine storm with immunomodulation in an induction maintenance treatment paradigm, and concurrently we should treat the underlying cause and prevent any complications. And in terms of COVID, we see the importance of switching off the cytokine storm with induction, no real need for maintenance, and treating the underlying cause with antivirals for the SARS-CoV-2 virus seems to be less of a priority, which is interesting again to reflect on. How do these concepts relate to COVID-19? Well, a biphasic model of COVID-19 is now well established, with an initial virumic phase, followed by an overlapping host hyperinflammatory phase at around day 10 in a subgroup of patients with an exuberant dysregulated immune response associated with high mortality. Now, this is hands down my favorite figure of the pandemic, elegantly encapsulating the complexity and need for strategic timing of immunomodulation to maximize benefit and minimize harm. The immune response in COVID may be helpful, antiviral immunity, or harmful, hyperinflammatory. And to me, it feels like there's a Goldilocks immune response to COVID: too weak with dominant viral damage to the host, too strong with hyperinflammatory host damage to the host, and just right where there's appropriate host antiviral immunity, with symptoms being mild to moderate and controlled. And although there are lots of opportunities for intervention, in this talk we're going to focus on immunomodulation or immunosuppression. There are so many, an avalanche, a tsunami of observational trials and interventional trials in this space. These are just some of the many drugs trialed in COVID, and we don't have time to go through all of them or even to try and make this slide as accurate as possible. Most of the evidence that has informed clinical practice has come from large platform studies from the UK. And a reminder of Recovery and REMAP-CAP study designs. Recovery is a large randomized controlled open label platform trial in the UK of hospitalized patients with proven or suspected COVID, randomized to no additional treatment, antiviral or host-directed therapies, with a primary endpoint of a 28-day mortality. There was simultaneous second randomization to convalescent plasma, and patients may have had, for example, no additional treatment with a control, or dexamethasone with convalescent plasma, and so on, a whole myriad of combinations. In patients with more severe disease, hypoxia and a raised CRP of greater than 75 milligrams per liter, they could have had a second randomization to receive either tocilizumab or control. And over time, many other drugs were added, including a comparison with high and low dose steroids, which we'll come to shortly. REMAP-CAP, a global randomized embedded multifactorial adaptive platform trial for community-acquired pneumonia, expanded for COVID, had a different population to recovery. Patients were in an ICU setting with organ support and were all within a 24-hour window of entering ICU or starting organ support. There were multiple arms, including immunomodulation. This is a nice schematic from a recent paper showing general concepts about SARS-CoV-2 infection. SARS-CoV-2 initiates after viral entry into epithelial or endothelial cells via the ACE2 receptor. Within the cell, the virus replicates and causes cell injury and death. Whilst dying, these cells release their content, particularly the proform of IL-1 alpha. This is a pro-inflammatory cytokine responsible for the early phases of inflammation. And following this stage, immune cells infiltrate the lung, namely resident macrophages, neutrophils, and dendritic cells that present antigens to T cells in the lymph nodes. And here B cells are responsible for the production of specific antibodies after SARS-CoV-2 against SARS-CoV-2. And this allows clearance of virus within a few days. So hyperinflammation, very expected entity to target, hopefully would also reduce hypercoagulability. We haven't yet shown that, but it seems logical. Let's look at steroids first. Now, we all know that dexamethasone 6 milligrams daily for 10 days reduces mortality in patients with hypoxia hospitalized with COVID. And these patients were receiving oxygen and or ventilatory support. Steroids reduce death by 1/3 in patients on mechanical ventilation, death by 1/5 in patients receiving oxygen, and no effect on death in patients not receiving oxygen, with a suggestion of harm in this population. Additional immunosuppression with tocilizumab and or baricitinib further reduces risk of death in these COVID patients with hypoxia, and we'll come back to that later. But let's look at high and low dose steroids. In recovery, the standard of care was dexamethasone 6 milligrams daily for 10 days or until discharge if sooner, and that was considered low dose. And high dose was dexamethasone 20 milligrams daily for 5 days, followed by 10 milligrams daily for 5 days or until discharge if this was sooner. Increasing the dose of corticosteroids into the high dose resulted in worse survival than low dose in patients with hypoxia not requiring ventilatory support. So no invasive ventilation, no non-invasive ventilation such as CPAP either. And therefore, we can conclude from this paper that was published in medRxives in December that high-dose steroids compared with low dose increase the risk of death, non-COVID pneumonia, probably bacterial pneumonia, and hyperglycemia, which all makes sense. The Data Monitoring Committee actually stopped enrollment of these patients, hypoxic patients not requiring ventilation, into this study, into the arm, but continued in patients requiring ventilation. And therefore, in those hypoxic patients requiring ventilation, we don't yet know the outcome and effect of high-dose steroids compared with low dose, but we eagerly await that. And this is really important data, I think, because of course, we all got very excited, and now this is all standard of care, and we're all quite chill about it. But 6 milligrams daily for 10 days of dexamethasone was a huge celebration. And that instantly also made us feel like, what if we went higher? Could we do better? And it's not better in this population, but we don't yet know about those hypoxic patients requiring ventilation. Before we move on to other drugs, I thought again, it might be helpful to reflect and take a step back on positive things that came out of COVID. Of course, it changed our lives for the worse in many respects, but positive things. I think our interpretation of clinical trials and therefore our design of clinical trials undoubtedly will get better. And COVID really helped us interpret clinical trials. It is not straightforward to celebrate or commiserate a so-called positive or negative trial. A lack of treatment response does not always refute efficacy of a drug, because this depends on a number of factors, including design. Recovery and REMAP-CAP were both open labeled. Components of the PICO framework, P, the population, the enrollment criteria, have we enriched for hyperinflammation? Have we defined it? Intervention, the time at which the intervention was initiated, relative both to the time of infection and to the severity of inflammation. Is there a window of opportunity that we illustrated in this figure? Intervening too early may be harmful. There was a suggestion of worse outcomes with dexamethasone in patients not requiring supplemental oxygen, and intervening too late may be futile. The dose, duration, and route of administration also really important, probably best exemplified by anakinra, IV and subcut dosing. The comparator, standard of care definitions changed over time by accrual of clinical experience, improved supportive care, and advancements in background therapies, and DEX became standard of care post-July 2020. And of course, the primary outcomes are also very different in all the trials. Co-primaries are usually harder to achieve. And are we looking at a hard primary endpoint of mortality or just progression? These concepts were very important when we were scratching our heads over this swinging pendulum of positive in orange and negative in gray studies. And it sort of feels like REMAP-CAP and recovery captured the sweet spot of where IL-6 inhibition really works the best. So So let's take a closer look at Covacta and REMAP-CAP, both tocilizumab studies, both published in the New England Journal of Medicine. Covacta was negative. It was a traditional double-blind trial. REMAP-CAP was positive, in inverted commas, open-labeled. That could have influenced decision-making. REMAP-CAP, patients were possibly more severe within 24 hours of organ support and ITU admission, but undoubtedly within 24 hours of ICU admission gives you a severity criterion. However, steroids really was the most massively glaring difference. The standard of care was different because the studies were conducted at different times. Only a minority of patients, 25% odd, received steroids in Covacta, less than the tocilizumab arm, compared with about 90% of patients in REMAP-CAP. And as an aside, around 80% of patients received steroids in the tocilizumab arm of recovery. And therefore, steroids probably really did swing that pendulum or push it further in that direction of positivity for REMAP-CAP. The meta-analysis of 27 randomized controlled trials of IL-6 receptor antagonists in patients hospitalized for COVID-19 showed a lower 28-day all-cause mortality with IL-6 blockade, significant mortality benefit only when combined with steroids, and the greatest benefit in those that needed respiratory support earlier in the disease course compared with invasive mechanical ventilation. Safety was reassuring, no increased risk for secondary infections at day 28 only, but the ascertainment of infectious adverse events varied and was quite limited in some trials. And therefore, in March 2021, the NIHR recommended tocilizumab in combination with dexamethasone for COVID patients on oxygen within 24 hours of an ITU setting, or with rapidly increasing oxygen requirements and significant markers of inflammation. Remember that 75 milligrams CRP criteria in recovery. Moving on to JAK inhibitors. So in July last year, we had the recovery publication in The Lancet, baricitinib reducing the risk of death in patients hospitalized for COVID, 12% allocated to baricitinib compared with 14% allocated to usual care died at 28 or within 28 days. The authors very helpfully created a meta-analysis that they published in this paper, really, really helpful, of all the 9 completed trials. That's 11,900 patients randomized with 1,500 deaths. Allocation to baricitinib or another JAK inhibitor was associated with a 20% proportional reduction in mortality with a rate ratio of 0.8. Consistent benefits in different patient groups, including by amount of respiratory support received and use of dexamethasone at randomization. Also, not pre-specified in the analysis, but there were consistent benefits in different patient groups, including by use of tocilizumab in combination with baricitinib or remdesivir at baseline. And we'll talk about that combination shortly. I wrote the linked editorial to the Lancet Recovery Study with my co-author, Buguma Titanji. And there are just a few things I wanted to highlight from this. First of all, you're not supposed to be able to read this giant table with tiny text that was in the supplement, but it's a nice reference paper, supplement for you to peruse if you want to get more details. And I'll share with you that actually this was inspired by the Cleveland Clinic talk that I gave last year on this same conference, where I had a lot of different trials side by side with PICO. And I remember when writing this editorial, the draft, I texted Buguma saying, shall I do what I did for the Cleveland Clinic talk? Because it actually worked really well. And so I did that for the supplement because it was too giant to include in the main article. But it really, really helped in terms of understanding all the different clinical trials. And I really think that we need to do this more often for RA, for PSA, for all of our rheumatological conditions. The 3 trials, Act 2, Act 4, and COV barrier, all mandated hypoxia. So these are the 4 baricitinib trials, and 3 out of 4, apart from recovery, mandated hypoxia. COV barrier also had a criteria for hyperinflammation, and they required a raised CRP, D-dimer, LDH, or ferritin, in addition to the hypoxia. The number needed to treat for COV barrier was much lower than recovery, 20 compared with 50, probably because COV barrier had selected the most severe patients, more likely to benefit from baricitinib, whereas the recovery eligibility criteria are really wide, and therefore the NNT was higher. Interestingly, although recovery had a CRP criteria and a hypoxia mandate for tocilizumab, they didn't have this for baricitinib. And that actually came as a surprise to me because I thought they would. And I think if they had, their NNT would have been lower. So taken together, the greatest benefit is probably in more severe disease, as evidenced by the subgroup analyses in ACT2 and COV barrier. And interestingly, again, important to reflect that COV barrier would have met the primary endpoint if they had selected mortality as the primary endpoint. They probably thought that it was too ambitious at the time of designing the trial, but if they had gone for it, the optics would have been so much different, so different in COV barrier's favor. But irrespective of optics, we really should digest this information as very supportive of baricitinib, and it all creates the picture of JAK inhibitors and efficacy in this space. In the editorial, we also talked about Bari versus TOC. Now, how do we pick between the two agents? Can we use the combination? First of all, both are welcome agents in addition to dexamethasone. And of course, tocilizumab was approved first. We all know that there were global shortages of tocilizumab and sarilumab for our patients in rheumatology who rely on these drugs to control their inflammatory conditions like rheumatoid arthritis, for example. So the addition of baricitinib at least eased the pressure somewhat off tocilizumab and allowed us to have greater choice and therefore less pressure on our patients who were really very worried about their drugs being unavailable for their chronic rheumatic diseases. Baricitinib may have better access. It may be cheaper in some countries. It's financial parity really in the UK, but I think it may be cheaper in America, where you are. Is there a steroid sparing effect in those high risk of steroid side effects? Act 4, very importantly, showed no efficacy difference between Bari and Dex, but there were less adverse events with baricitinib, and therefore, should we opt for baricitinib alone without dexamethasone, where patients have very high steroid side effect risks, like brittle diabetes, for example? Something to discuss. And although we know that JAK inhibitors cause simultaneous suppression of multiple cytokines and a broader immunosuppressive effect, I tend to see it as carpet bombing the immune system. They do have a shorter half-life and therefore more rapid washout when discontinued in the event of adverse infections, or in the event of adverse events, I should say, like secondary bacterial infections and so on. Tocilizumab may be preferred in some situations, special considerations, for example, pregnancy where there's greater clinical experience, and in children where we have more convenient dosing and extrapolation from SGIA, for example, even though we're using JAK inhibitors in that space as well. Now, the combination is fascinating. Do you remember we talked about the 2 randomizations? So a patient could have got baricitinib as well as tocilizumab, which resulted in 23% of patients in recovery having both tocilizumab and baricitinib. And although the authors state that there's little data for meaningful interpretation, even though the numbers were massive, their analyses show that the effects of baricitinib were consistent, irrespective of combination tocilizumab. And importantly, I just want to mention that we know that all of these drugs, baricitinib, tocilizumab, and dexamethasone, can increase the risk of GI, gastrointestinal perforation, as well as suppression of the CRP. And therefore, the triple combo may be a little risky. And we come back to the fact that can tocilizumab and dexamethasone suppress the procalcitonin as well as the CRP when trying to detect infection? I could have shown you slides and slides on procalcitonin. I decided not to because the jury's out. We really don't know. We really need to do this work and collect that data. And I don't think it's that difficult because it's going to be such useful information for both the COVID space, but also our patients in rheumatology practice requiring interleukin-6 and JAK inhibition. I would thoroughly recommend this resource if you haven't seen it already in the BMJ, very user-friendly reference, the Living World Health Organization guideline on drugs for COVID. And here, interestingly, the update has corticosteroids, IL-6 blockers, and baricitinib. All 3 may be combined. Is that what you do? I'd love to hear in the discussion. So most physicians in the UK tend to use dual agents, so Dex plus Toc or Dex plus Barry, and then sequentially adding in the other, baricitinib or Toc, depending on what one they haven't had, if the patient doesn't improve. Now, by that point, is it futile? Is it throwing the kitchen sink at something that is not going to have much benefit? Should you go hard early, all in, by giving 3 agents in someone that has very poor prognostic signs? What does that mean? I'd be really interested to hear what you think. IL-1 inhibition, I still have a soft spot for. However, RCTs of anakinra show different results. Now let's look at why. Core immunoana, the open label negative study, stopped for futility, versus the Save More Nature Medicine double-blind positive study that reduced progression and conferred a 55% reduction in mortality. Why is that? The population in core immunoana were mild to moderate with a very low CRP threshold, only 25 milligrams. Save More was very innovative, enriched for SUPAR, a biomarker of impending respiratory failure that we'll talk about later. And the more severe population, 90% of patients had severe pneumonia. The dosing regimen in core immunoana was heterogeneous, variable, complicated. But curiously, although the Save More anakinra dosing regimen was a bit more stable, and a bit more tight, the anakinra dose was only 100 milligrams subcut. But importantly, steroids were discretionary and variable in core immunoana, but 86% of patients received steroids and Save More. To add complexity, Anaconda, another anakinra study, was suspended due to a numerical excess in mortality. And based on Save More, a few months ago, anakinra received a positive opinion of the EMA, and in November 2022, the FDA authorized emergency use authorization, so EUA, for anakinra to treat hospitalized COVID patients with pneumonia requiring supplemental oxygen and at risk of respiratory failure or increased SUPAR levels. Now, I think the SUPAR is fascinating because we can't measure it in the UK. It would be awesome if we could, but we can't. And I'd be really interested to hear if you can. Another cytokine that I have a soft spot for is GM-CSF. For me, GM-CSF, the pro-inflammatory immunoregulatory cytokine, exemplified the complexity and challenges of drug trials in COVID. There's rationale for both therapeutic blockade as well as recombinant administration of GM-CSF. And GM-CSF has important roles in homeostasis, antiviral immunity, and hyperinflammation. And there really were some beautiful basic science studies showing the value of targeting, the rationale of targeting GM-CSF in COVID. But alas, the trial results of GM-CSF blockade were very mixed, summarized in both these editorials by us on the right in the Lancet Rheumatology, and then Katerina Kohler and Andrew Conway-Monis in the European Respiratory Journal, ERJ, fairly recently. The negative studies included OSCAR, which was the otilimab GSK study, which initially had a signal of efficacy in those over 70s, which was then abrogated in the follow-up, the longer-term study in that OSCAR-More study, which was a shame. And although there are some positive live air of lenzilumab and catalyst namilumab studies, the data really hasn't taken off, and I'm still not sure what's happening in this space. Importantly, namilumab has been taken forward in recovery, so very large platform study, and let's see what happens there. So maybe we'll be talking about this next year. I think what's fascinating is the flip side of the argument, which I talked to you about earlier, that actually inhaled GM-CSF treatment may be something that is of benefit to boost antiviral immunity. And this paper in Cell by Bart Lembrecht and colleagues showed a lack of alveolar macrophages and defective GM-CSF instruction in COVID patients, or lack of response. But inhaled GM-CSF in patients with COVID was safe. It may improve oxygenation and boosted virus-specific T-cell responses. So these pro-inflammatory macrophages turned into homeostatic alveolar macrophages in response to inhaled GM-CSF, cleaning up debris, improving dendritic cell function and adaptive immunity and improving that gas exchange. So this SARPAC trial with inhaled GM-CSF is exciting and something to look forward to. It's just published a couple of months ago, so let's see what happens. Well, what next? Well, we talked about, look how far we've come. But here I'm sort of thinking, we haven't really come that far in terms of predicting treatment response. So this all started from a data-deprived hypothesis of cytokine storm as a mechanistic basis of critical COVID-19 pathogenesis. And given the success of immunomodulation, it's now widely accepted that these patients have a dysregulated hyperinflammatory immune response, but we still do not know which patients are likely to benefit and how can we refine which drug to use. There are criteria for hyperinflammation, but what do they mean? We have some biomarkers, CRP, ferritin, SUPAR. We need to move from prognostic to predictive. And can we measure SUPAR? What's the point of having a great biomarker that that we in the UK can use? I'd be interested to hear what you can do. But it'd be nice to have something that we can actually use to predict response and help us select between tocilizumab and baricitinib. And we still don't know about genetics, interferon signatures, and autoantibodies in the treatment space in terms of therapeutic predictive response. So in conclusion, immunomodulation reduces mortality in a subgroup of patients with severe COVID-19. We've shown you randomized control trial evidence for dexamethasone, tocilizumab, JAK inhibitors. We don't know how to really position IL-6 receptor antagonists and JAK inhibitors, and the combination is unclear. And there is some data emerging for IL-1 and GM-CSF blockade. It would be nice to have a head-to-head, difficult to position the Barry and TOC data, but let's see what happens. Hyperinflammation in COVID is a new and distinct entity. There's lots of criteria proposed, but we need multivariate models and immune profiling. And we really need to try and move biomarker discovery forward from prognostic to predictive to optimize therapy. And we've talked about SUPAR being a companion biomarker for anakinra, but it'd be great to have something more clinically feasible to measure. And the impact of genetics, interferon signatures, and autoantibodies is yet unknown. So my voice did hold out just about. I'd like to thank you for the invite again, and thank you for your attention, and look forward to discussions in the Q&A. Thank you so much.